Pharmacokinetics is what the drug does to the body, which is ADME. Absorption, distribution, metabolism, and excretion. Absorption, entry of drug into the bloodstream. Distribution, drug movement throughout the body. Metabolism, chemical alteration, mainly in the liver. Excretion, elimination of drug metabolites, urine, feces. These four processes determine drug levels in the blood and tissues, how it gets metabolized and then eliminated. Routes of drug administration. There are different entry paths for a drug into the body, each chosen based on how fast the action is needed, where the drug needs to go, or drug stability. Oral route. Easy, common, but affected by digestion and first-pass metabolism. Edgy. Paracetamol, amoxicillin. Rectal, avoids some first-pass effect and shows action where needed. Egg, diazepam. Rectal gel, inhalation, direct to lungs for rapid action. Egg, salbutamol injection. IV, drug goes directly into the blood, e.g. ceftriaxone. IM, it has slower absorption and longer duration, e.g. vaccines. SC, the drug directly goes into the fat layer, e.g. insulin. ID, drug is injected just under the skin, e.g. BCG vaccine. Sublingual buccal route, drug is kept under tongue or in cheek for quick absorption and to bypass the liver. E.g. nitroglycerin and midazolam. Mechanisms of drug absorption. 1. Passive diffusion. Drug moves from high concentration to low concentration directly through membranes. As it is a passive process, it does not require energy or carrier proteins. Drug molecules should be small, lipophilic, non-ionized. Example, aspirin. Most oral drugs use this because it's simple and energy-free. 2. Facilitated diffusion. Drug moves from high concentration to low concentration, but uses a transporter protein. It is called facilitated because a carrier protein facilitates the movement without energy. Drug should be larger or hydrophilic, water-loving molecules. Example, glucose via GLUT transporters, used when a drug cannot dissolve in fat membranes and needs help to cross. 3. Active transport of the drug against concentration gradient, low, high. So it requires energy, ATP, and a carrier proteins for its movement. Drugs should be large or charged drugs. Example, levodopa via amino acid transporter. This mechanism allows essential or structurally similar compounds to be absorbed efficiently, even when natural diffusion wouldn't allow it. 4. Endocytosis. Pinocytosis. A type of active transport where the cell membrane wraps around the drug molecule, forming a vesicle that brings the substance into the cell. It uses energy in the form of ATP. Drugs should be a large molecule, macromolecules, protein drug complexes, drugs that mimic endogenous ligands. Examples, vitamin B12 absorbed with intrinsic factor, iron transferrin complex, some monoclonal antibodies and nanoparticles. Note, endocytosis is essential for absorbing large or complex molecules that are too big or too hydrophilic to cross membranes by diffusion or carrier-mediated transport. Factors affecting absorption. Drugs like 1. pH and ionization. The pH of the environment, acidic or alkaline, and the drug's chemical nature, acid or base, affect whether it is ionized, charged, or non-ionized, neutral. Only non-ionized, uncharged drugs can easily cross lipid membranes. Ionized drugs are water-soluble but not lipid-soluble, so they're poorly absorbed. Weak acids, e.g. aspirin, are better absorbed in the acidic stomach. Weak bases, e.g. morphine, are better absorbed in the alkaline intestine. Mechanism. Based on the Henderson-Hasselbalch equation, pH affects the ratio of ionized to non-ionized forms. 2. Blood flow to the absorption site. It refers to the circulation of blood at the site where the drug is administered. Drugs must be picked up by blood vessels to enter systemic circulation. How it affects absorption. High blood flow has faster absorption of the drugs, e.g. muscles. Low blood flow has slower absorption, e.g. fat tissue or during shock. Example, in shock or hypothermia, blood flow to the skin and gut is reduced, slowing drug absorption. 3. Gastrointestinal, GI, motility and contact time. It refers to how fast contents move through the digestive tract, especially the intestines, where most drugs are absorbed. The longer a drug stays in the absorption area, e.g., small intestine, the more it can be absorbed. How it affects absorption. When the person has diarrhea, the drug will be for less time, which reduces the absorption. When the person has constipation, gastric stasis, the drug stays in the body for more time, increasing the absorption. Some drugs are absorbed in specific segments of the intestine, so transit time through that segment is critical. 4. Surface area of the absorption site. The total area over which the drug can be absorbed. The larger the surface area, there will be more space for absorption. The small intestine has a very large surface area due to villi and microvilli, making it the primary site for most oral drug absorption. How it affects absorption. More surface area has better absorption. Reduced surface area, e.g., in inflammatory bowel disease, celiac disease, gastroenteritis, has poor absorption. 5. P-glycoprotein, PGP, efflux pump. It is a transmembrane protein found in the cells of the intestines, brain, liver, and kidneys that pumps the foreign substances, like drugs, out of the cells. In the intestines, it can pump drugs back into the gut lumen, reducing the absorption. How it affects absorption. High PGP activity. Drugs are pumped out, reducing the absorption. Low PGP activity. More drug is absorbed. Some drugs inhibit or induce PGP, affecting the absorption of other drugs. Multi-drug resistance, MDR, in cancer therapy is often due to overactive PGP. Drugs like digoxin are affected by PGP levels. What is bioavailability? Bioavailability, F, is the fraction or percentage of an administered dose of drug that reaches the systemic circulation in an active form. IV, intravenous route, where 100% of the drug is reabsorbed because the drug is injected directly into the bloodstream. Oral route, PO. Here, 100% of the drug is reabsorbed due to incomplete absorption in the GI tract and first-pass metabolism in the liver or gut wall. Bioavailability tells us the actual amount of drug that becomes available to produce therapeutic effects. Oral doses often need to be higher than IV doses to achieve the same effect. Bioavailability is measured using the AUC, area under the curve, of the plasma concentration time graph. AUC represents total drug exposure over time. A drug with higher AUC means more drug is available in blood and has higher bioavailability. Factors affecting bioavailability. 1. Solubility and permeability. This says how well the drug dissolves and crosses the cell membranes. Lipophilic, fat-soluble drugs cross membranes easily and has better bioavailability, whereas hydrophilic or large polar molecules has poor permeability and has low bioavailability. Example, propranolol, lipophilic, has good oral bioavailability. Vancomycin, large, hydrophilic, has poor oral absorption, so it is given IV too. Chemical instability in the GI tract. Some drugs are destroyed by the stomach acid or digestive enzymes before they can be absorbed. If the drug breaks down before absorption, less active drug reaches the blood. Examples, penicillin G, destroyed by gastric acid so it is not given orally. Insulin, broken down by digestive enzymes, must be given SC or IV3. First-pass metabolism. The drugs absorbed from the gut first go to the liver via the portal vein, where they may be partially or completely metabolized before reaching the bloodstream. Significant metabolism in the liver can greatly reduce bioavailability. Examples, nitroglycerin undergoes extensive first-pass metabolism, so it is given sublingually to bypass the drug distribution. Distribution is the process by which a drug moves from the bloodstream to various tissues and organs in the body after it has been absorbed or administered. It determines which tissues receive the drug and in what amount, influences dosing, especially in conditions like obesity, sepsis, or liver-kidney disease. The major factors affecting distribution. 1. Blood flow to tissues. The rate of perfusion, blood supply to different organs. Organs with higher blood flow receive more drug quickly. High blood flow has rapid distribution of the drug, e.g., brain, liver, kidneys. Low blood flow has slower distribution of the drug, e.g., fat, bone, cartilage. Example: in septic shock, blood flow is redistributed so it affects the drug levels and efficacy. 2. Capillary permeability, the leakiness or tightness of capillaries that affects the drug movement out of blood vessels. Capillaries in some tissues, like liver, spleen, are more porous, allowing drugs to pass through more easily. Tight junctions, like in the brain's blood-brain barrier, restrict access to drugs unless they are lipophilic or have transporters. In inflammation or sepsis, capillary leak increases, leading to drug leakage from blood and has lower serum concentration. 3. Plasma protein binding. Many drugs bind to proteins in the blood, especially albumin. Only the free, unbound drug is pharmacologically active. High protein binding has less free drug, and this decreases the tissue distribution. Low protein binding has more free drug, increasing the distribution and possibly toxicity. In chronic kidney disease or liver cirrhosis, plasma proteins are reduced, so there is more free drug, higher risk of toxicity. Example: phenytoin is highly protein-bound and has slow release leading to prolonged effect. 4. Lipid solubility of the drug. Solubility. Lipophilic, fat-loving drugs easily cross cell membranes, distribute widely into fatty tissues and organs. Or hydrophilic, water-loving drugs stay mostly in blood plasma or extracellular fluid. Example: anesthetics, lipophilic, rapidly enter brain and fat. Gentamicin, hydrophilic, stays in extracellular fluid and has limited tissue penetration. 5. Volume of distribution, VD. Volume of distribution is a way to describe how much a drug spreads out in the body after it enters the bloodstream. Formula, VD, bioavailability, X dose divided by plasma concentration, C plasma, low VD, 0.2 liter per kg, mostly stays in plasma, moderate VD, 0.2–0.7 liter per kg, moves from plasma and goes into extracellular fluid, high VD, 0.7 L per kg, enters cells and tissues. Examples: 1. Theophylline dose, 500 mg. IV plasma concentration is equal to 20 mg per liter. After entering the values in the formula and calculating, we get VD is equal to 0.5 liter per kilogram, distributes in total body water, so the drug is moderately lipophilic. 2. Gentamicin dose, 100 mg IV. Plasma concentration is equal to 8 mg per liter. After entering the values in the formula and calculating, we get VD 0.25 liter per kilograms. So the drug is low to moderate lipophilic, stays in extracellular fluid, good for bloodstream infections. Let us continue. Chapter 2 in the next video.